Rick Bevins, and I have the privilege of serving as the director of the Rural Drug Addiction Research Center. Before I introduce our speaker, I'd like to recognize that today is Veterans Day. And I want to take a moment to thank all the veterans for their selfless service. On this day, I often think of like my Uncle Freddie that served in Vietnam. Now, luckily he was fortunate enough to make it back, unlike so many, and he actually just celebrated his 50th wedding anniversary. And then I also think about my grandpa Elliot, who is no longer with us, but he served in World War II, and when I was a kid, he sort of taught me the love of fishing. So just a moment of sort of pause here to thank you for your service and just to reflect on all of our loved ones and to thank you. So it is my absolute pleasure to introduce a friend, a colleague, and our closing keynote address. I was so thrilled when he agreed to do this. So Dr. William Stoops is a professor in the departments of behavioral science, psychiatry, and psychology at the University of Kentucky. He got his bachelor's degree in psychology from Davidson College, and then a master's degree and his PhD at the University of Kentucky. So he has been a wildcat for a long time. His research evaluates the behavioral and pharmacological factors that contribute to drug use disorders, focusing primarily on stimulant drugs. He has a very extensive publication record. In my NCBI, it lists 138. And of course, we all know that system doesn't do the greatest job of counting everything that you have out there. He also has 4 NIH grants at this time to fund this work. At least that's what I could find digging around. Among his research, he is leading a clinical trial evaluating non-abstinence outcomes in cocaine use disorder, and is also the principal investigator on human laboratory studies determining the role of orexin and serotonin 5-HT1B system and abuse-related effects of cocaine. Dr. Stoops has a very extensive service record to the discipline. He is currently president of the College of Problem and Drug Dependency Board of Directors and serves as editor of the Experimental and Clinical Psychopharmacology. I have had the great privilege of working with him very closely for many, many years as part of the American Psychological Association, where I have served, but he has served as Division 28 president. And he recently beat me out on the votes for a council representative, which we all knew he did. So that's the only reason I ran, because I didn't want to do it. So because I knew Bill would be amazing at it. So with that, no longer, let's have Dr. Stoops take the floor, and I wish there was a loud applause button on Zoom, so thank you so much for joining us.
Oh, thank you, Rick. I will say I'm happy, well, I'm not happy to have won the Council of Representatives position, but maybe next time you can take it on. It's we just met, and it was a doozy of a meeting. So anyway, I'm really, really happy to be with you today. And thank you, Rick, for that great introduction. And thank you for asking me to present. Let me share my screen and we'll go ahead and get started. Well, did I do that right? How's that look? Everybody okay with that?
Works great.
Okay, great. So thanks everybody again. I'm gonna go ahead and get started. Let me see. Sorry, let me escape out of this. This is not working exactly the way I wanted to. There we go. Let's do this. Much better. All right. So I'm going to talk today about translational research on how we've used non-drug reinforcers to reduce cocaine use. Of course, if you want to reach me, this is my email address. I check it entirely too much. You can get me pretty much any hour of the day. And I'm somewhat active on Twitter. This is my Twitter handle if you'd like to check out what I've got to say there. So I want to make a few acknowledgements. I'm going to be presenting some research of our own, out of our lab, as well as others' research. Most of this was funded by NIH, but I want to make clear that the opinions I'm expressing today are solely my own and do not represent NIH's views, and I have no relevant conflicts of interest to declare. So I've got 3 objectives for today's talk. First, I want to provide an overview of US substance use epidemiology and focus on cocaine. Then I want to move to sort of the meat of my presentation and describe translational research that has evaluated how we can use alternative reinforcers to impact cocaine use. And then I know we've got some folks who are interested in policy and advancing treatments out in the community. So I want to spend the last part of my talk talking about how we may be able to do that, how we may be able to advance this approach as a treatment. Considering existing models of this treatment approach and policy, as well as thinking through some of the criticisms that have been levied about this approach. So let's start by talking about the epidemiology of substance use in the United States. So these data come from the National Survey on Drug Use and Health. And for those of you who aren't familiar, this is an annual survey that is conducted with individuals age 12 and older who are housed. And it's done in a way that it's intended to be representative of the entire US population. So from this survey, these are 2019 data published in 2020. Over 60% of Americans report some type of drug use within the past month. So they're currently using some drug. Majority of this is attributable to alcohol and tobacco, although we've got quite a few folks who are using marijuana as well. When we look at sort of the next groups of commonly used drugs, we've got RX, pain reliever misuse. So this is prescription opioid misuse at about 3 million current users. And where cocaine's right here, 2 million current users in 2019. The most commonly misused stimulant drug. When we look at substance use disorder, so the number of people in the country who exhibit problems with their drug use, that's a smaller number, but it's still a sizable portion of Americans. It's 7.4% of Americans meet criteria for past year substance use disorder. Again, this is really largely attributable to alcohol use disorder, and then they bundle everything else into illicit drug use disorder. And under illicit drug use disorder, we've got things like marijuana use disorder, pain reliever disorder, and then here we're seeing methamphetamine and cocaine being equal. But again, very, fairly common use disorder among people who meet criteria for a substance use disorder in general. And there's a real need for treatment and treatment access. So on this graph, I'm showing you on the left panel, the percent of individuals needing substance use treatment in the past year from 2015 through 2019. I'm going to draw your attention to this orange line with the triangles. Because this is individuals age 12 and older. So this is the overall population in the United States age 12 and older. And this number's been pretty stable. This is right around 7.5% over the past 5 years, despite everything we've done to try to intervene and provide treatment. When we look at the subset of these people who need treatment, who are actually able to access treatment, it's only about 10%. So very, very few people are actually really able to access any level, any type of treatment in the United States. And this, again, has been stable despite everything we've done over the past years. So what's available and where can it be accessed? So I'm sure that most folks on this call know that or on this Zoom know that we've got medications approved for alcohol, tobacco, and opioid use disorder, which is great. But these can still be difficult to access, particularly for alcohol and opioid use disorder, because those treatments require a physician's prescription. For tobacco, you could get NRT, but if you want varenicline or bupropion, you also have to go to a physician. We have no medications for any other substance use disorders that have been approved by the FDA. There are diverse non-pharmacological interventions, which I'm going to talk about in just a second, that have been researched and deployed for pretty much any drug, but has really been done in a patchwork fashion. So if you look at what type of treatment people have accessed in 2019, 2.1 million are accessing treatment through a self-help group. So this is like Alcoholics Anonymous or Narcotics Anonymous. Then folks are accessing it throughout outpatient centers, outpatient rehabilitation, outpatient mental health centers. Very often, these outpatient centers don't have a physician who can prescribe a medication to treat substance use disorder. When we look at sort of these next inpatient rehabilitation, private doctor's office, hospital, inpatient, folks are likely able to access medications here, and but we see it. It's just decreasing. It's just these places are less commonly accessed, are much less commonly accessed than a self-help group is. And then perhaps some commentary on treatment access availability in the United States. Some folks are getting their treatments at emergency rooms or in prisons and jails. that's where they've got to go to get their treatment. And to me, that's really unacceptable. That's a place that is where it's commonly accessed, with the exception of understanding that if that's all they can get, that's better than nothing. Being able to get it in an emergency room or a prison or jail. So going back to this slide where I showed you past month US substance use epidemiology, I want to revisit the idea that we've got medications for sort of these most commonly used drugs: alcohol, tobacco, pain relievers, opioids, and heroin. We do not have medications for then the sort of next most commonly used drugs: cannabis and cocaine. Today's talk is going to be about cocaine and advancing treatments for cocaine. So let's spend just a little bit of time talking about cocaine use disorder epidemiology. In this top panel, I'm showing you the percent of people in the United States who have indicated past year use of cocaine from 2002 to 2019. Again, I'm going to draw your attention to these triangles to focus on the general population age 12 and older. And while there has been some decrease in use from 2002 down to about 2011, we've been pretty stable, hanging right around 2% of the US population reporting use of cocaine in the last year. When we look at people meeting cocaine use disorder in the past year, again, there's been some reduction in the general population from 2002 to about 2009. But we've just hung sort of stably at about 0.5% of the United States population is using cocaine in a way that they would meet use disorder criteria. And despite everything we've tried to do to change that. So to reiterate what I've just said, cocaine use and use disorder rates remain stable. Unfortunately, cocaine use overdose deaths are increasing. Some of this can be attributable to opioid co-involvement, particularly where people who are using cocaine use it and it's been adulterated with an opioid like fentanyl and they overdose for that reason. So if we could stop them from using cocaine, we could potentially stop this opioid co-involved overdose. Not only that, what I think is really, really critical for folks to know and to understand is that cocaine overdose, or cocaine use, but cocaine overdose in particular, is a health disparity and health equity concern. And I'd always sort of suspected this was the case, but I saw some data in 2018 that just made me really stand up and pay attention. And this was data published by Shields and colleagues in 2018 that showed that overdose death rates in Black people were comparable to those of overdose death rates in white people. And look at what we've done to help combat the opioid overdose crisis. But what's even more stunning from these Shields data is that the cocaine overdose epidemic in Black people is more prolonged. We saw those rates that are now equivalent to those of opioid overdose death rates in white people for 10 or 12 years before we saw the opioid crisis come on in white people. So it's a prolonged epidemic. It disproportionately affects Black people, older people, and people with low educational attainment. And all of this has been magnified by the COVID-19 pandemic. It was bad before, but it's even worse because of the COVID-19 pandemic. So although cocaine use disorder in and of itself is a problem, absolutely 100% people are dying from it, it's associated with a range of other health complications. People who use cocaine are more likely to acquire sexually transmitted infections. We need to revisit these numbers, but I don't know, 5 or 6 years ago when we were writing a paper, we went and looked at HIV acquisition rates in people who use cocaine in the NSDUH data, and we found that people who use cocaine after you control for injection drug use, so they aren't acquiring HIV through injection drug use, were 27 times more likely to have HIV than people who didn't use cocaine. I'm going to say it again, not 27%, 27 times more likely to have HIV than people who didn't use cocaine. They're more likely to be diagnosed with mental health disorders. They're more likely to smoke cigarettes. They're more likely to experience cardiovascular problems. People who use cocaine have other problem behaviors. They have trouble with impulsivity. They engage in risk-taking to a greater degree than people who don't use cocaine. So what is cocaine use disorder and how do we diagnose it? So on this slide, I'm showing you the 11 bullets that are 11 bulleted points that are abbreviated versions of what the DSM 5 criteria are that an individual can endorse to meet cocaine use disorder. And I've underlined some key phrases here: taking more cocaine than you intended, or using longer than intended, trying to cut down or stop your use, but being unable to do so, continued use in the face of problems, or continued use in harmful situations. So we define cocaine use disorder by drug-taking behavior, particularly by dysregulated drug-taking behavior. And that leads to how the FDA has thought about approving a pharmacotherapy for cocaine use disorder. The FDA wants any medication that you bring forward as a treatment for cocaine use disorder to completely disrupt this behavior. What the FDA wants to see is a medication that promotes complete abstinence from cocaine in the final 3 weeks of a clinical trial, to a greater degree than placebo. That's a really, really high bar. And I think that's part of why we don't have a medication to treat cocaine use disorder. Non-pharmacological interventions can target use, but something that's nice with non-pharmacological interventions is that we aren't tied to that FDA complete abstinence bar. Non-pharmacological interventions can target other outcomes. So what do we have that's available? So I've said it, I'm going to say it again. There are no approved medications for cocaine use disorder. In a paper we wrote with Paul Zodi in 2016, there were more than 60 medications that had been tested in 100 clinical trials for cocaine use disorder. Nothing has been advanced. Agonist treatment, as shown in this more recent meta-analysis, specifically use of amphetamine isomers in cocaine use disorder, is effective, but has yet to be advanced for a number of reasons. And that could be something we can talk about at the end of the presentation if you'd like. We do have some behavioral interventions that have shown efficacy. These 4 interventions have been endorsed by NIDA as having an evidence base to support their use in cocaine use disorder. So we've got cognitive behavioral therapy, community reinforcement with abstinence reinforcement, which is really what I'm going to be focusing on today, individual and sort of group drug counseling. Again, going back to that point about where people access treatment in general, there is no universally used or approved approach for treating cocaine use disorder. And I think that's contributing to some of our problems, why we're seeing persistent, stable levels of cocaine use and cocaine use disorder in this country. What I'm going to spend the rest of today talking about is translational research that shows the utility of using alternative reinforcers as a very powerful way to reduce cocaine use. So I'm going to start with preclinical research. For those of you who know me, I'm a human laboratory researcher, but I started in a preclinical lab, and everything I do is always founded on preclinical work. So I'm going to spend a little time talking about early research in this area that was conducted with non-human primates, and then I'm going to show some subsequent research that was conducted in rodent models. Then I'm going to build on that and talk about recent work that has built a homologous cocaine alternative reinforcer choice model in non-human primates and humans. And that was done in our lab as a way to sort of show how this effect can be conserved across species if you really, really tightly match the variables. Bottom line is all of these studies serve to demonstrate parameters that are important for how alternative reinforcers influence cocaine intake. So let's start with sort of the probably easiest one to think about is alternative reinforcer magnitude. This was a paper published by Mike Nader and Bill Wolverton in 1991, and they were doing work with rhesus monkeys. And they had trained these monkeys, to self-administer food pellets, a range of them from 1 up to 16, each pellet being 1 gram, and cocaine doses from 0 to 0.56 milligrams per kilogram per injection. They then gave monkeys a choice between these 2 options, food and cocaine, with either the amount of food available being held constant and the drug dose being varied, or the amount of drug available being held constant and the food amount varied. To again, really get at the idea of how does alternative reinforcer magnitude, the number of food pellets, how does that impact cocaine choice? So here are some outcomes from this study. These are actually individual monkey data in each of these 4 panels. I'm going to focus on this top left panel, M8624, but the general pattern of results is similar across monkeys. So on the y-axis is shown percent of drug choices. So the percent of times the monkeys are choosing that cocaine dose. On the x-axis is the cocaine dose, cocaine doses available to this monkey. I'm gonna sort of use the one pellet, the cocaine dose versus one pellet choice as an anchor here. So that's the open circles. And what you can see is that as the cocaine dose response, the cocaine dose goes up, you see increased preference or increased choice for cocaine over that one food pellet. Pretty standard, what we would expect to see. However, as we increase the number of food pellets available in any given choice, we see that that dose response curve shifts down and to the right. So when 4 food pellets are available, which are the closed squares, or closed circles here, my apologies, we see, again, increased cocaine choice as the dose goes up, but we have to go to a higher dose, almost double, to get nearly maximal drug choice in this monkey. When Mike and Bill provided 16 food pellets to cocaine, even that dose is only chosen 50% of the time. So alternative reinforcer magnitude, as you increase the alternative reinforcer magnitude, you're suppressing drug choice. This was then followed up by a number of studies, but the one that I want to focus on here was done by Morgan Thompson and colleagues and published in 2013. And this is a study that was done in rats. And instead of food pellets, what they did was vary drinking liquid concentration of ENSURE from 0 to 56%. And rats were choosing between that varying ENSURE concentration and a range of cocaine doses from 0 to 1 milligrams per kilogram per infusion. And the animals were given a choice between those two options again, as the liquid concentrations of the cocaine dose varied across sessions. I'm going to focus here on the top panel, which is percent of cocaine choice as a function of ENSURE concentration. Again, along the x-axis is the unit dose of cocaine. Let's again anchor ourselves with the 0% ENSURE concentration. And when even when placebo is available, but across the cocaine dose response curve, you see near maximal drug intake when it's just basically water, when there's 0 ENSURE in the drinking water. As you increase the ENSURE concentration, you go to 5.6%, you do see some suppression of drug intake. But when you get to 18 and 56% ENSURE concentrations, you see near complete suppression of low dose cocaine intake. But then, as you get to this higher dose, this 1 milligram per kilogram per infusion dose is it's a pretty hefty dose. It's a pretty powerful reinforcer and hard to overcome. So you see, near maximal drug intake. Although also just to point out on this bottom slide, which is total number of reinforcers, there's not a whole lot of behavior going on here. These rats are not self-administering a whole lot of drug at this dose. All right. So, another factor that we might want to think through about being important is response requirement. Making either the drug more difficult to earn or making the food more difficult to earn. So this was a paper published by, again, Mike Nader and Bill Wolverton in 1992, done in rhesus monkeys as a follow-up to their 1991 paper. And in this study, they trained the monkeys to self-administer food pellets, 1 or 4. So they varied the magnitude again here and cocaine dose from 0 to 1 milligram per kilogram per injection. And they gave animals a choice between 2 options, with either both options being available at the same response requirement, for a fixed ratio 30. So to earn a food pellet would be 30 responses on a lever, and to earn a cocaine dose would be 30 responses per lever. Sometimes though, they increase the response requirement for cocaine relative to the food response requirement. Other times they increase the food response requirement relative to the cocaine response requirement. So here's some of the data from that study. This is data for 1 pellet. I'm not showing you the 4 pellet data because it's pretty similar. And this is when the one pellet is available on an FR30. And they actually have group mean data here on this bottom right panel. So I'm gonna just talk about that. On the y-axis again is percent cocaine choice. Along the x-axis is cocaine dose. Just like with the rats, with the monkeys, previously, let's focus on the equivalent response rate. So cocaine available on an FR30, 1 pellet available on an FR30 as our anchor here. We see just what we would expect to see. As the cocaine dose increases, we see increased cocaine choice. As you, though, increase the cocaine response requirement, so this open squares line is when cocaine's available in an FR 120 and 1 pellet of food is available in an FR 30. We see some shift in the dose response curve, not a lot, but some shift in the dose response curve down, particularly for this low cocaine dose. But when you make cocaine much harder to earn than 1 pellet of food, and again, remember, 1 pellet of food is not a particularly strong reinforcer. So cocaine's available on FR 480, 1 pellet of food is available on FR 30. You see near complete suppression of drug intake, down to 25% of choices being made for drug, and the remainder being made for that 1 pellet. Morgan, Thompson, and colleagues followed this up with a rat study. Again, this is that same paper published in 2013, where they trained those rats to self-administer food pellets and cocaine. And similar to what Bill and Mike did, they sometimes increased the response requirement for food relative to the response requirement for cocaine. Other times, they increased the response requirement for cocaine relative to food. So I want to focus again on this top panels, but I'm going to start with the panels on the left. And these are data for what happens as you change the FR requirement, the ratio requirement to earn food relative to cocaine. So again, to anchor ourselves, let's focus on this FR food 5, because cocaine is also available on a FR 5. We see this sort of prototypic dose-related increase in cocaine choice when the response requirements are equivalent. When food is easier to earn than cocaine, so it's FR1 versus FR5, we see a suppression of drug intake, sort of on the same magnitude we saw with the monkeys. So some suppression at this lower cocaine dose, but near maximal intake as we get to this high cocaine dose. When we make food harder to earn than cocaine, rats shift, the response curve shifts to the left. So rats increasingly choose cocaine doses when food is harder to earn relative to that cocaine reinforcer. The converse is also true. So again, anchoring ourselves at these closed circles, we can see that there's this when cocaine and food are available on the same ratio responding requirement, prototypic dose-related increases in cocaine choice. When we make cocaine easier to earn, we do shift the curve. We see that the curve is shifted up a little bit, again, at this low cocaine dose. When we make cocaine harder to earn than food, we see suppression of drug intake with about 50% choice when cocaine is available on an FR 45 relative to food being available on an FR 5. All right. Let's move to just a summary of the preclinical findings. So cocaine choice is responsive to the presentation of alternative reinforcers. It's not this magical thing that doesn't respond to the presence of alternatives. I think that we all in the field recognize that cocaine is a powerful reinforcer and changing cocaine taking can be really difficult, but it's absolutely achievable that as you increase that alternative reinforcer magnitude, you decrease cocaine intake. As you make the alternative reinforcer easier to earn relative to cocaine choice decreases. Just like I said, though, the reverse is also true. If you flip these things, you can increase cocaine choice. Not something we would necessarily want to do, but just sort of shows the lawfulness of this relationship. I want to just note that many other parameters like deprivation or satiation from food or cocaine, prior history of self-administration have been evaluated. I'm not able to speak to those today and actually keep in my allotted time. So, but I do want to just spend a little time talking about work that our group has done with colleagues at VCU to develop a homologous human non-human primate model. So this was a series of studies. The first paper with the monkeys was published by Amy Johnson. And then the second paper with the human results was published by Josh Lyle, who was actually the PI for the whole protocol, done in rhesus monkeys and humans. And again, we did this because, the idea of translation is really, really important, but there's so many sort of differences between animal models and human models. We wanted to try to make the models as tightly connected as possible. So we had monkeys, we gave monkeys and humans the opportunity to choose between food for the monkeys and money for the humans is the alternative reinforcers. So 0 to 10 pellets, or a penny up to $3. And then cocaine. For the monkeys, it was 0.43 milligrams per kilogram per infusion. For the humans, it was 0 to 30 milligrams per 70 kilograms per infusion. And these are the exact same doses on an infusion basis, on a weight-based basis. And in each session, the organism under study, the rhesus monkey or the human, had a total of 9 choices. So aside from the alternative reinforcers being different, and I'll talk about why we didn't use food in humans in a little bit, these were identical experimental conditions. So I'm not going to walk through these slides, these figures, in as much detail as I did on the past slides. I will note that on the top panel are the monkey data, and the bottom panel the human data. And as the panels go across, it's the alternative reinforcer increasing in value from left to right. So 1, 3, and 10, a penny, $1, and $3. What I want to note is that across these instead of percent cocaine choice, it's number of trials that they chose drug. So, or that they made a choice for drug or money, or omitted their responding. So it's not a percent choice so much that in these figures, but the cocaine, and it's with cocaine dose along the x-axis. The point from the previous slides remains the same. As you increase the cocaine dose across all of these conditions, you see increased cocaine choice, exactly what we would expect. However, as the magnitude of the alternative reinforcer increases, you see suppressions in drug intake relative to lower alternative reinforcer magnitudes. I want to spend a little bit more time though on this slide. And this was, our way of really understanding how homologous this model was. So along the x-axis, on the y-axis for each of these panels is the number of cocaine choices made in humans under any given condition, either the placebo cocaine dose up through the high cocaine dose, correlated with the number of cocaine choices in monkeys. And I'll just, and what this panel show are low alternative, medium alternative, high alternative value, but I'll just spend talk about the collapsed alternative. We see near perfect alignment. We've got an R squared of 0.98. I don't think I've ever seen an R squared of 0.98 come out of our lab before. So really, really, really tight correlations in terms of choice as a function of cocaine dose across alternative reinforcer values. So just as I showed you with the preclinical data, cocaine choice is responsive to presentation of alternative reinforcers. Again, as you increase that magnitude of alternative reinforcer, you decrease cocaine choice. As you increase the cocaine dose, you increase cocaine choice. The self-administration outcomes are tightly correlated across those 2 studies and 2 species. And then, so now I want to use this as a bridge to move to human laboratory work that is sort of further evaluated the parameters related to cocaine and alternative reinforcer choice. So I'm going to focus on similar parameters evaluated to those that, I'm going to focus on similar parameters to those that have been evaluated in non-human animals, but human laboratory research is extended to understand how type of alternative reinforcer can impact cocaine intake. This is the work that I do day in and day out. So I sort of take it for granted that a lot of folks don't really understand how this work is done in humans. So we can talk about more details later, but just some basics, because these are the questions I tend to get when I give presentations like this. There are a lot of hoops we've got to jump through, but basically all of this work is conducted in individuals who are actively engaged in cocaine use, and we verify their use. We rigorously screen them prior to enrollment for contraindications to giving them cocaine. All subjects provide informed consent, and none of them are seeking treatment for any of their drug use. So the first study, that I think really came out on this was published by Steve Higgins in 1994, and this looked at alternative reinforcer magnitude. And I won't show you these data, but I want to make clear that cocaine functioned as a reinforcer in these individuals. So the initial session, they did an initial session where they had these enrolled individuals make 10 choices between intranasal cocaine, 10 milligrams in placebo dose, just to demonstrate that these individuals preferentially chose cocaine over placebo and that it functions as a reinforcer in these folks. What I am going to show you the data for are subsequent sessions in which they had these individuals make 10 choices between cocaine and money, values ranging from $0 to $2, and each of these conditions was tested twice. So here are the outcomes. These top four panels are individual subject data. Along the x-axis, or the bottom shows you the group average. That's the graph I'm going to describe in more detail. Again, on the y-axis is cocaine choices, along the x-axis is money rather than dose, because there's just a single cocaine dose tested here. The open squares are the first exposure, the closed squares are the second exposure. Outcomes are pretty similar across, with the exception of this 50-cent condition. But basically, when no money's available, these subjects select all the cocaine. That's what we would expect. As we increase the alternative reinforcer value, you see this really sort of nice suppression of drug intake with a complete suppression of drug choices at this $2 cocaine condition, or $2 alternative reinforcer condition, excuse me. Thinking about response requirement, again, back to those studies by Mike Nader and Bill Wolverton and Morgan Thompson, we published a study about this in 2012. And in this study, we had subjects sample a range of intranasal cocaine doses, 5 to 30 milligrams. And then we had them make 8 choices between that sample dose and a quarter. The cocaine response requirement across all sessions was 100. So it was available on an FR 100, 100 responses to earn that cocaine dose each choice. We varied the money response requirement across sessions. Sometimes it was easier to earn than cocaine, much easier on an FR1. Sometimes it was much harder, available on an FR 1000. And here are the outcomes from that study. On the y-axis is number of drug choices. Again, the maximum number of choices is 8. On the x-axis is the cocaine dose, 5 to 30 milligrams. Again, sort of to provide an anchor for our perspectives, I want to talk first about when the FRs are equal between the two choices. So that's this FR 100, these triangles. So both cocaine and money available on those following 100 responses. We see a dose-related increase in cocaine choice that flips over at this high 30 milligram dose. We don't often see a bitonic dose response curve in humans, but every so often we do observe one. When we make money harder to earn, when we make that alternative reinforcer harder to earn, we increase cocaine choice. So you can see this, basically just upward shift in the dose response curve for cocaine when money's harder to earn. When we make money easier to earn, when we make it easier to get that alternative reinforcer, we see a suppression of drug intake, not a complete suppression. And we'll talk a little bit later about sort of perhaps reduction in use rather than complete abstinence is something we need to be thinking about. But we do see a reduction in drug intake at both the FR1 and FR10 values when money is available at lower response requirements. Moving to alternative reinforcer type. Again, this is something that we've looked at more in humans than I think we've looked at in animals, in non-human animals. So this is the first study I want to talk about is a study published by Carl Hart in 2000. And in this study, subjects sampled a range of doses of smoked cocaine, 0 to 50 milligrams, and then they made 5 choices between cocaine at either a $5 money voucher or a $5 merchandise voucher. So they could only exchange it for like goods of some sort. Here are the outcomes from that study. Along the y-axis is number of cocaine choices, again, a maximum of 5 choices available in any given session. And cocaine doses from 0 up to 50 milligrams. When it's the merchandise voucher, you see a slight increase in drug intake relative to when it's a money voucher. So there's reduced drug intake when it's a cash voucher available relative to a merchandise voucher. We wanted to follow this up, and this is the study where I'm going to talk about why we didn't use food as the alternative reinforcer in humans. In a study that we published in 2010. So we had subjects sample either placebo or intranasal cocaine, and then we had them make 6 choices between that dose and either money from a penny up to $1 or a preferred food item from also valued at a penny for $1. So Josh Lyle and I actually went to the grocery store and figured out what you could get in Lexington, Kentucky for a penny or 10 cents or a penny or 50 cents or $1 or whatever. And we presented that in a menu to the subjects, and they picked their most preferred item. And they then were given that item when they selected food over drug. And I saw a comment in about potentially about the anorectic effects. And I'll come back and we could talk about that in humans or in the animals. But in humans, we wanted to get around that. So we actually delayed the provision of the alternative reinforcers. We just gave folks tokens, basically both for money or the food item, saying like, you've earned this item, and then they could exchange at the end at the end of the session for the actual reinforcer. So we didn't have to contend with the anorectic effects because we didn't expect them to consume all their food or use all their money within that session. So here are the outcomes. Number of drug choices, a maximum of 6 on the y-axis, value of alternative reinforcer along the x-axis. These are data for the money alternative reinforcer. These are data for on the left panel. These are data for the food reinforcer on the right panel. Placebo cocaine dose is shown in the circles. Our active cocaine dose is shown in the squares. Just a note, for a long time, we don't actually do this much anymore, but for a long time, we used a 4 milligram intranasal cocaine dose because it produces numbing, and so helped us maintain the blind. But it doesn't really produce blood levels or subjective effects. So what first, I think is probably apparent from both these slides is that active cocaine is chosen to a greater degree than placebo, pretty much universally. But I think what's more important, what's more striking, is how much more effective money is as an alternative reinforcer relative to food in people. So when we look at active cocaine dose choice, we see pretty strong suppression of drug intake, such that they're only really choosing about 1/3 of the doses that are available across these range of alternative reinforcer values. There is some effect of value, such that the dollar is suppressing it more than a penny, but it's not quite as robust as we had seen sort of in the monkey and the rat data, with the magnitude being really, really important. When we look at food, it's a terrible alternative reinforcer in humans. We see near maximal drug intake when food is the alternative reinforcer relative to money. All right, so to summarize human laboratory findings, cocaine choice is responsive to the presentation of alternative reinforcers. As the alternative reinforcer magnitude increases, cocaine choice decreases. Again, this is not always the case, though. Similarly, as the response cost for alternative reinforcer decreases, cocaine choice decreases. So you make that alternative reinforcer easier to earn, you decrease cocaine choice. Moving one step forward, cash is a more effective alternative reinforcer than non-cash alternatives. Again, just like with preclinical data, other parameters, severity of use, order presentation of alternative reinforcer values have been evaluated. But taken with preclinical findings, alternative reinforcers exert a powerful effect on cocaine intake. And I'm going to now move and talk about how clinical trial findings align with those from the laboratory. So I want to talk about the initial sort of seminal trial that demonstrated efficacy, and then I want to talk about some subsequent studies that looked at alternative reinforcer magnitude, alternative reinforcer type, and some novel treatment delivery methods. But I want to note that there's a whole lot more that's been done with this that I just can't cover today. So the initial trial published by Steve Higgins in 1991, and they took treatment-seeking people with cocaine dependence and either assigned them to receive alternative reinforcers when they provided objective evidence of cocaine abstinence. So when they came into the clinic and provided a urine sample that was negative for cocaine and its metabolites, they received an alternative reinforcer. They received vouchers for exchangeable for money or services. And then the second group was assigned to sort of standard 12-step Narcotics Anonymous counseling over a 12-week treatment period. Here are the outcomes. These are both showing the number of subjects who achieve some level of continuous abstinence from 1 week out to 12 in the treatment period. The behavioral treatment, the abstinence reinforcement intervention, is in the filled bars. The hash bars are the NA treatment. The top panel is when you count missing values as positive, and the bottom panel when you count missing data as negative. So I'll just focus on the cocaine positive, the presumed positive outcomes. Across the 12-week trial, you see much greater proportions of individuals assigned to the behavioral intervention able to achieve abstinence. So even out to 11 weeks, 40% of the people in that abstinence reinforcement condition are able to achieve, are able to be abstinent. They're abstinent for 11 weeks continuously. It's like incredible relative to the NA treatment. Steve has followed this up with a body of work. If you haven't read it, I certainly encourage you to do so. But I do want to talk about a study that he did that looked at alternative reinforcer magnitude. And this was done in treatment-seeking subjects with cocaine dependence. Again, they assigned one group to receive high-value alternative reinforcers. So they could earn about $2,000 across the trial if they provided urine samples consistently negative for cocaine. The second group got low-value alternative reinforcers, so about $500 available across the trial. It's a 24-week treatment period with alternative reinforcers available for the first 12 weeks. And this is showing, similar to the last graph I showed you, the percent of subjects achieving some level of continuous abstinence. So their duration of continuous abstinence across the 24-week trial. The closed bars are the high voucher group. The open bars are the low voucher group. And out to 12 weeks as alternative reinforcers are available. We're seeing, up to the point where alternative reinforcers remain available is 12 weeks. 40%, again, in this high voucher group are able to achieve that level of abstinence. It's just, again, incredible. But even after the alternative reinforcers go away, we see people able to achieve, 20 to 30% of people able to achieve 22 weeks of abstinence from cocaine continuously. Just really, really incredible. Nothing we would typically, we see with any other intervention. Thinking about alternative reinforcer type, this was a study published by Ryan Vondre in 2007. Again, treatment-seeking subjects with cocaine dependence. These folks were actually also methadone maintained. And this is with the subject's design. It's actually really interesting. And they assigned folks to goods-based alternative reinforcers where they provided cocaine evidence of cocaine abstinence, cash-based alternative reinforcers across a range of values. And this was done in random order, and there was a washout between conditions. They did this over 16 weeks. So here are Ryan's data showing you percent overall abstinence across the range of values, with vouchers shown in the sort of dotted bars and cash vouchers shown in the filled bars. And it's only when we give cash, or when Ryan gave cash at high values, $50 and $100 for being abstinent, that you see a separation where you're seeing significant increases in abstinence from cocaine. So alternative reinforcer type matters in the clinical trial as well. Now, I want to move and talk a little bit about novel treatment delivery methods because that's relevant to what I'm going to close with. So Nancy Petrie pioneered this idea that I'm going to talk about here. This is a paper she published with Bonnie Martin in 2002. And this was done in response to concerns about how expensive it is to provide an alternative reinforcer, particularly a high value alternative reinforcer, every time somebody provides objective evidence of having been abstinent. So this was done, this is sort of the advent of the Fishbowl method. And so what I mean by that is one group was assigned to receive prize-based alternative reinforcers for cocaine, and this was also an opioid maintained group, so opioid abstinence plus standard treatment. So every time they provided objective evidence of cocaine abstinence, for example, they were given a number of draws from a fishbowl. And in that fishbowl are slips of paper that say, some of them say, great job, keep it up. So, no reinforcer at all, except for sort of a positive message and affirmation. Sometimes there's a low value, but sometimes there's a high value. So, it's a relatively inexpensive way to provide alternative reinforcers that don't mean you're delivering an alternative reinforcer that has a high value every single time. The second group was assigned to standard treatment alone, and this was done in a 12-week trial. So I want to draw your attention to this bottom panel. These are the results for cocaine abstinence from this Fishbowl method across the 12-week trial. So the percent of cocaine negative urine samples observed, the closed circles are the active contingent treatment, the Fishbowl method. The open squares are the standard method. So across the 12-week trial, you see separation with up to 75% of samples being provided being negative within across that 12-week treatment period. And what I think is astonishing is that on average, patients in the CM condition earned about $140 worth of prizes. So not a huge investment there to get some significant levels of abstinence from cocaine in these individuals. Another novel treatment method came out of Ken Silverman's laboratory. And this is a paper he published on this method in 2007. And it's called the Therapeutic Workplace. And so in this therapeutic workplace, and in this particular study, they enrolled individuals who injected cocaine who are also methadone maintained. And they enrolled them in the therapeutic workplace where they could earn $10 per hour in vouchers. One group was assigned to having to be abstinent from cocaine. in order to work and get their $10 per hour in vouchers. The second group just got work alone. They could come in and work whether their urine was positive or negative for cocaine. It's a 30-week trial, and the last 26 weeks were the work period where the contingencies were in place. So in the baseline period, so that first 4 weeks of that 30-week trial, when you look at work only or abstinence and work, you see relatively low levels of cocaine negative urine samples. What does that look like? About 5 or 10%. When we look at, when they enter the intervention period, you see pretty substantive increases in cocaine negative urine samples in the group assigned to having to be abstinent. So we're up to about 30 or 40%. So not quite as impressive levels of percent negative samples as Nancy Petrie got in that study I just showed you. But if we think about it, you've got a 5 or 6-fold increase in cocaine abstinence in this intervention. So clinical trial findings: providing alternative reinforcers effectively reduces cocaine use to a greater degree than standard treatments. The findings are consistent from the laboratory to the clinic that as alternative reinforcer magnitudes increase, cocaine use decreases. This isn't always the case, though. Nancy Petrie was able to use relatively low alternative reinforcer values and get cocaine abstinence. And the type of alternative reinforcer influences the outcome. Innovative and creative approaches have been successful in promoting cocaine abstinence. So what do we do? What do we do with all this translational evidence supporting this approach for treating cocaine use disorder? So I want to consider the support we've got for using this method to reduce cocaine use. The accumulation of evidence. I've shown you just a small amount of it today. Accumulation of evidence supports this treatment as approach in cocaine use disorder. In fact, a recent meta-analysis found that contingency management stands out above all other treatment approaches for its efficacy in reducing cocaine use. There's even support from the current Biden-Harris administration. So I took this out of an early memo from like February of 2021 around drug policy in the Biden White House. That in the first year, the Biden-Harris administration will work with ONDCP to coordinate with other White House components in the interagency to identify and address policy barriers related to contingency management interventions for stimulant use disorder. Now, there are a whole bunch of other things they wanted to do, but this is a call out for contingency management from the president and the vice president, which is incredible. Nothing we had ever seen before from previous administrations. So who's using it? Who's using this approach? Because I think that's important to consider. The United States VHA, Veterans Health Administration, so speaking of veterans today, uses this as an evidence-based approach. The United Kingdom National Health Service uses it. For a while, California was considering it. And in fact, their House passed a bill that allowed their Medicare or Medicaid program to use contingency management to treat substance use disorder. But unfortunately, Governor Newsom vetoed that bill. He was concerned that that the state needed to conduct a pilot project. To me, I feel like there have been enough pilots if I've shown you all the data, but there are concerns about cost. And I'm going to talk about that in a second because it was really opposed by the finance department. It had bipartisan support, but the California finance department had concerns about it. So what do we do next? We continue to advocate as researchers for use of this effective approach because there's nothing else available to offer people in need of treatment. We don't have medications. It's hard to access other treatments. So we need to continue to advocate for the use of this. And we need to consider the ongoing criticism. I'm going to talk about each of these in turn, but I would also encourage you to check out this website, and I can give Callie my slides that really does a nice consideration of the pros and cons of contingency management for treating cocaine use disorder. So first, is that it costs too much? Absolutely. Traditional abstinence reinforcement approaches can be very costly on a per patient basis. So individual clinics can't implement it, but these large scale health organizations like the VHA or the NIHS are able to adopt it. So maybe that's what we've got to be thinking about. And there are adaptations that can reduce costs. The Fishbowl approach, you can see effects with people earning as low as $40 to $70. The Therapeutic Workplace can offset costs because people are earning an income from that work. And there have been some cost-effective analyses that show, of course, it is more expensive than standard treatment, but it can be cost-effective depending on how a clinic might value the sort of longer abstinence you see with this approach relative to others. If you look at special populations, particularly unhoused populations, it actually isn't necessarily any more costly because it offsets costs from drug use in those populations. So if you intervene with contingency management in those groups, there's a lot of benefits that can accrue. It doesn't work in the long term. Absolutely, doesn't work in the long term. Is a huge criticism. Patients often return to use after ending the intervention. This is true for many medical problems. After you stop taking your antihypertensive, your high blood pressure is going to come back. After you stop taking your antidepressant, probably your depressive symptoms are going to come back. In fact, I turn that on its head and say, when you turn off the intervention and the problem comes back, that's an indicator of the effectiveness of this approach. Some studies have looked at the durability of its effectiveness. I'm going to talk about 2 of them. And then there's also this idea that you can combine treatments to make them more effective in the long run, particularly the sleeper effect, the idea that you put CBT and contingency management together. Contingency management works in the short term, then the CBT sort of sleeper effect takes hold and folks are able to really apply what they learn in CBT to promote abstinence in the long term. And I'm going to show you some data from that from a study in 2014. So durability of effects. These are from that Higgins high-low voucher alternative reinforcer study from 2007, or trial from 2007. And I want to draw your attention to the follow-up. These are 6 to 24 months after treatment. And this is the percent of individuals abstinent after they've left treatment. So even at the 24 months, you're seeing the folks that they're able to follow up with achieve being, up to 50% of them being abstinent out to 24 months. So there is some durability of effect there, but that is not always the case. As Kim Kirby showed when you have, in this study, she either had folks receive sort of standard treatment where it sort of turned off after 12 weeks or receive extended treatment out to 36 weeks of alternative reinforcers. So as long as the reinforcers are in place, these black circles here, you see, 30 to 40% of the samples being abstinent. When you turn it off again, it goes, the effect is not durable. So, I think that is a legitimate criticism. But one we can hopefully overcome with combined treatments. So these are the data that I talked to you about from Pettyjohn and colleagues in 2014. They assigned folks to either an experimental group that got CBT and contingency management, or that just got control treatment. And and in the sort of first 12 weeks, you can see that CM effect coming on with up to 70% of samples being negative for cocaine. And then you see some and after the alternative reinforcers are turned off after 12 weeks, you see that effect sustained in this experimental group, ostensibly produced by sort of the cognitive behavioral therapy skills they're receiving. You're paying people to do something they should already be doing, that age-old criticism. Well, my response to that is always that actually what you're doing is you're providing an evidence-based behavioral intervention. You're giving people treatment for something that they need. And in fact, we actually all receive rewards and incentives to engage in various target behaviors. So what is it about helping people not use cocaine that makes it so bad? And I would argue that there's nothing wrong with it. And it's the stigma that many apply to substance use disorders that somehow makes this idea of abstinence reinforcement worse. Lastly, I think, what we're really doing is offering choices and options to people who have very limited options in the first place. Okay, so this one is sort of the big one that we're sort of wrangling with now, is the idea of anti-kickback statutes. Again, going to the idea that, the federal government paying for it through Medicare, Medicaid, sort of large health systems. It is true that the Center for Medicare and Medicaid Services imposes annual limits on incentives as a way to prevent fraud and abuse. Completely legitimate, absolutely something they should do. But the Veterans Health Affairs Administration doesn't see abstinent reinforcement as an inducement or as an incentive. They think of it as a treatment. And this is consistent with NIDA's and SAMHSA's viewpoints. 16 groups wrote to OIG to request a change to this anti-kickback statute and add contingency management alternative reinforcers as a safe harbor to promote, as a way of promoting drug abstinence, to add a safe harbor provision so that they aren't considered kickbacks. And that was done in February 2021. We know the federal government moves very, very slowly, so the next steps remain to be determined. So just some conclusions before I jump to questions. Translational research shows that providing alternative reinforcers reduces cocaine use. Magnitude and type of alternative reinforcer matter. The response requirement is also important. And I think that's something we haven't thought about so much in clinical trials. Thinking about broader implementation, some large-scale health organizations have implemented it, but there are criticisms and legal concerns that pose barriers. I like to flip it and think on the bright side. I think those are avenues for future research. Those are things that we can do to help address those concerns and those barriers. Bottom line is we see that alternative reinforcers promote abstinence. But to sort of come back to this idea of sort of non-abstinence outcomes, which is something I'm really, really interested in. We know cocaine use disorder is more than just cocaine use. So we need to be thinking about, is there bleed over from promoting abstinence to other non-abstinence outcomes? Or could we even use this intervention to target other outcomes and not even really spend too much time thinking about abstinence and thinking about what the patients need? When you talk to somebody with cocaine use disorder, sure, they want to stop, but they also want to have better relationships with their family. They want to, be more engaged in a job. Lots of times the use seems secondary to them relative to other sort of quality of life things. And so with that, I will stop and take questions. So thank you all very much for your attention.
That was amazing, Bill. Thank you so much. It was
My pleasure. My
wonderful.
pleasure. Oh my goodness.
Preclinical to policy and everything in between. Wonderful. So I want to make sure that you fully got Eric's first question, which is there an interaction with cocaine being an appetite suppressant and how it affects the essential value of food as a reinforcer? So just want to make sure we did do justice there.
Yeah, sure. So absolutely. So that's a terrific question, Eric. Completely something that we need to be thinking about. I think that goes to a lot of what we have done in preclinical models is sort of, some level of food restriction in animals, right? However, my recollection of a lot of the some of the monkey work is that it's all they're sort of free feed, and they still choose those alternative reinforcers as you increase the magnitude. Maybe less the case with rats. I think you probably do have to food restrict them a little more to get those outcomes. But for humans, we really were attentive to that. We didn't want to have that issue in place. So really, really good question.
So I guess the people in your study, because that was an amazing study, Bill. I had forgotten about that work until you showed it. But it was like, but the people weren't motivated for food, right? There was no establishing operations of deprivation or anything, right?
No. So yeah, so just a little more about how we do our, so we maintain our folks in a hospital, so they get sort of standard hospital meals. If anything, they actually gain weight while they're on the unit. So yeah, we did not have any sort of deprivation, which actually could have also contributed to our findings. Beyond just food not being a great alternative reinforcer in people. So
right, and it's the challenge of translation, right?
It is very much the challenge of translation, because I can't give a rat or a monkey $1 bill and have them know anything that's going to be able to do anything with it. So
no, the rat will make a nest out of it.
Yes, that's right. That's right.
So Eric has another question next in the queue. People in recovery often discount monetary reinforcers when they are actively using. Does the efficacy of alternative reinforcers depend on the severity of the cocaine use dependence or abstinence time?
Wow, yeah, no, that's a great question. So yeah, so let me tell you that delayed discounting is real. So in the clinical trial that I'm currently running, we started with, so I didn't spend a lot of time talking about this, but there have been really sophisticated arrangements where, you escalate the alternative reinforcer value as people continue to be abstinent. So the first abstinent sample is $5, the next one's $7.50, the next one's $10, so on and so forth. So they build up value, right? We could not get it to work because the participants could just not understand, like they couldn't string together that they had to be abstinent in the long term to get those high values. So I just said, okay, I've got to have abstinence in this study, because really what we need to know is how do changes of cocaine use impact all these other non-abstinence outcomes. So we're just giving them $50 every time they provide a negative sample, and that works a whole lot better. So that doesn't specifically address Eric's question, but he's right that the delay discounting is really important and is real. I think, there is individual subject variability in response to contingency management, and there's any number of factors that are driving that. So severity of cocaine use disorder likely, absolutely is playing a role. I think probably what we need to look at is, what does their delayed discounting look like? And then how do they respond to contingency management? And I'm certain somebody has done that study, and I'm certain I've read that study, but I couldn't tell you off the top of my head. My guess is that people with more delay are just less responsive, or more discounting are just less responsive to CM. Yep. To the other point, yes, absolutely. As those alternative reinforcement values increase over time, yes, those people really do come to value it. And I think there's a time when you can overcome that delayed discounting that you're seeing, right? You just got to get there. Like I said, in that trial, like, we just couldn't get people there. We did worksheets where they could accurately describe what would happen if they didn't use for a period of time, but they just couldn't get there.
Super interesting. So Ken Wakabayashi is asking, given that both the preclinical and clinical literature suggests that people with cocaine use disorder have disrupted cost-benefit processes associated with gambling, is it ethical to incorporate a random chance element, Fishbowl, as part of their treatment? Ooh. Huh.
Yeah, no, that's a great question. And that's sort of one that Nancy Petrie really wrestled with, as she was doing it. So I'll come back and talk about the ethics of it in just a second, but her study, her work showed that putting that fishbowl in play didn't change gambling behavior, didn't make folks more risky, didn't make them engage in sort of gambling with their earnings or not, any of those kind of things. And she even looked, I think, at sort of like folks with past gambling experience, and that it didn't make it worse. And I think some of that's in context of treatment. I think as far as sort of the ethics of that, we do have to be really careful there, right? We have to be thoughtful of, are we going to exacerbate a condition? Are we going to make it worse for folks? I think, again, Nancy's data show that we're not, so it's okay to sort of proceed. But I also come back to the argument of, there really truly is nothing. If I have one of my participants, they come and participate in research, that's some treatment they can get. But otherwise, if they're out in the community and they're trying to stop using, they show up at an overloaded community care center that maybe is delivering some individual counseling, maybe delivering some group counseling, but really there's very few alternatives. There's very few options available. And so, that doesn't mean that it's okay to just do it, and have to be very thoughtful about it. But I think it's worth proceeding with, given that Nancy's data really do pretty soundly show it doesn't exacerbate gambling in these folks.
Thanks, Bill. Yeah, so I was really glad that you brought up stigma, an issue of stigma within the context of the policy and just general perceptions. I guess I would love to hear your thinking on what can we do about that. I know it's hard, but where can we start? This is,
yeah, my goodness.
I've just been trying to get my mind around. It's just killing me.
Yeah. So yeah, I mean, I think we are making steps. I think the idea is that we are, the field is thinking about people rather than disorders. So, we're using person-centered language, person-first language. We're thinking about the whole person and what they want. I've been able to attend a few really interesting sort of federal government seminars from the FDA and from CDC, where they're hearing from people with the disorder or families who are affected by the disorder, so we can really understand where they're coming from. So that's great, because we're bringing it out of the shadows. Wonderful. But I think the next thing we need to be thinking about is, how do we gather data on stigma, and how do we and how do we combat stigma? And I think the social psychology field is light years ahead of us in thinking about stigma. So I think we need to be thinking about in groups, out groups, how you can sort of change those things and start thinking about how to apply that in the substance use disorder. We have a T32 here at UK, and in one of our more recent discussions, and actually we're going to be having a panel with these folks, there are sort of these unions of people who use drugs, and either they're in recovery or they're actively using drugs, and they're saying, you're gathering data from us, you are writing about us, but you're not involving us in the process. And so I think we really need to be talking with folks who've got lived experience, either active lived experience or past lived experience, family members, and ensure that they feel included, but that they're meaningfully included, right? Not just that we go and talk to them and say, hey, what are your ideas? But if they come to us actively, that we listen to them, and that we don't just say, well, we're the academics, we really know what we're talking about here, right? And now that's not to say that I believe that you've got to have lived experience to be an addiction researcher. I don't necessarily think that that's the case, but I think that all of our work is enriched by understanding people who have lived this and have had to navigate it, because we miss it. We miss stuff when we're just sort of in the lab.
Sorry, I'm taking notes. Oh, holy, whew, man. So I have something, Kelly, I think a lot about how in the previous session, Dr. Jim Berry began a thought by saying, when we try to solve the patient's issue and then quickly change to when we work alongside them, that was quite meaningful, even if it was just an utterance.
I agree. I think that's exactly where we are. I think that's exactly where we need to be going. Because, again, if somebody is not comfortable talking to you about their substance use disorder as a clinician, you're not going to be able to help them, right? Because they're going to hide it from you. But I think we're entering the next stage where we've really got to think about it scientifically. And let's borrow from our brother and sister disciplines, and pull that in, right? So
I resonated to your phrase, meaningfully included. That's really important. Really important.
Good. Awesome. Work is cut out for us, huh?
Not going to quit my day job anytime soon.
No.
So I'm going to take the luxury of the last question, because we're running out of time, and I do believe it'll take you the time. So it's very, very hard to do the kind of translational work you've been doing, where you take that preclinical work and you pull it into the human laboratory and then start thinking about it within the context of clinical trials. And I guess I'd like to hear some of your pro tips or your challenges. Just give me the James Joycean kind of stream of consciousness.
Oh my goodness.
What comes to mind when you think about that? Yeah.
So the first thing I'll say is, it takes the whole field. I've been lucky to be immersed in an institution that really, and this, Rick, you were there. We've got the molecule out to the community. And so I've been able to live it. I think that's really, really hard to do at a lot of places, right? Because so you've got to have, so if you can't get that within your institution, look for it sort of at neighboring institutions to sort of really enrich that knowledge base that's around you. Because so I think that, that's one thing. The other thing is, at least for me, I always look for inspiration to preclinical research. I always look to what is happening in the rat and the monkey and what are we seeing? And then how can I bring it into the humans? Again, at UCAM, I'm really lucky that I'm in a place where I can actually do these controlled studies in humans. And there's a whole lot more to that, which is a whole different talk for a different day. But it allows me to actively translate it, but I always do it with a collaborator. So I just got this 5-HT1B grant, but Janet Niswander, who did the preclinical work, is a co-investigator on the project, because I don't know, I need her help to bring this into the humans, right? And then, and I will also say, to me, to advance something to a clinical trial, it's got to work in the rat or monkey and the human in the lab, and then you push it to a clinical trial. That's when it's going to be effective. You've got to have that pipeline across. And I think we feel like we desperately need something, so we jumped to the clinical trial right away with a new chemical entity. But you can save money and effort if you do those first things first. It takes just a couple of years, and then do a clinical trial, as opposed to we've been doing clinical trials for cocaine use disorder since 1987. So
60 medications, 100 trials. I was blown away by that number. I almost fell out of my seat.
Yeah, and there are more. It's like up to 64, 65 now. So yeah, goodness. But I mean, translation is where it's at. It's what you've got to do, and you've got to work collaboratively. And to that point about meaningfully included, you've got to meaningfully include your colleagues across the translational spectrum, right? You got to talk to them, and you've got to. So I'll stop there since it's 4:30, and I know folks have been on Zoom a long time. So
No, wonderful. Thank you. Thank you so much.
We need to fail faster. Yes, yes, I agree.
Yeah, right. So I know everybody's at their Zoom desk. Like, thank you so much, Bill. Amazing.
My pleasure. Thank you so
Learned
much.
tons. So I really appreciate you being the closer keynote for us. I couldn't have done it. I couldn't have been any better or any more wrapped up than that. So with that, I've been assigned a few closing comments. So first, symposium evaluation, vigorous clapping resumes. Yes, thank you, Callie. Absolutely. So in your inbox now was likely to be symposium evaluations because we have an amazing evaluator as part of the center that is all over this. So, and I plead with you to fill them out. I know we're all tired of surveys because we get them from, I just have my brakes fixed on my van, and guess I got a survey like 3 times for just that. So, but we really need these both to improve what we're going to do next year. And we also need them because we have to report them to NIH as part of our reporting for the centers. And so it should be in your inbox now, hopefully. I also want to just say from my perspective, this symposium probably reflects what's an unprecedented collaboration across COBREs, INBREs, and institutes. There's 5 of us. We have the Rural Drug Addiction Research Center, COBRE, the COBRE for Opioids and Overdose, the West Virginia INBRE, the Center for Addiction and Disease Risk Exacerbation, COBRE, and the West Virginia Clinical and Translational Science Institute. Love our partners. They are amazing. It has enriched all of this in our experiences, and I have no doubt we'll continue to improve and build on these collaborations. I would, of course, be remiss without thanking the members of the Symposium Planning Committee. And this Symposium Planning Committee reflects the diversity of the centers involved. So I want you to please join me in thanking Devin Crawford, Gail Fraser, Stephanie Ballard Conrad, Daniel Morgan, Hillary Richards, Haley Horn, Delia Elsade, Michelle DeOrsay, and there are many, many others that have been involved in abstract reviews, research presentation monitors, poster hosts, and I've got a number here that over 50 more people were required just to make this roll out. This is not including the participants. Now, I had to laugh when I saw this list because the list was sent to me by our own Callie Patterson. And she's not on the list. She didn't put her name on the list. I was like, what? So I want to give a huge shout out to Callie for all of the work she's done. You recognize her name from the emails. You'll recognize her name. She's the one been pulling the strings behind the Zoom and making it all work. So thank you, Callie. Thank you, everyone, for all of your help with all of this. It could not happen without any of you. I also just have to say that I'm just blown away that, so on top of all the people that helped make it work, there is an additional 130 folks outside that were involved in attending the symposium. So that's amazing. So with that, I know we will see you at other events. Until then, happy collaborations, and may your p-values always be less than 0.05 and your R-squareds be equal to 0.98. So thank you, everyone. You're amazing, and we'll see you soon. So Bill, take care. Love to see you. Can't wait to see you in person soon.